Assalamu alaikum wa rahmatullahi wa barakatuh. Dear colleagues, health and safety are the two major concerns in each organization in every country. Therefore, Emirates Society of Ophthalmology, in collaboration with Bayer, have taken the initiative to distribute slit lamp breath shields among all the ophthalmologists within UAE. Wishing you to stay safe.
Thank you for the ESO and Bayer for their initiative to provide medical shield for the slit lamp. I will be fitting it on the slit lamp here. It fits well in place and with a good thickness to provide safety and security for all of us as ophthalmologists. It fits for the slit lamp and the laser machine.
For generations, people have trusted Bayer for solutions that promise to live healthier lives and provide sustainable support. These solutions are ever important nowadays. For that reason, protecting the safety and well-being of our doctors is paramount commitment in our partnership journey.
Where together, in collaboration with ESO, we can pave the way for a better and safer future for the ophthalmology community and their patients in UAE.
Assalamu alaikum wa rahmatullahi wa barakatuh. Dear colleagues, good evening. Let me first introduce myself. For those who doesn't know me, my name is Noura Qassimi, Vice President of Emirates Society of Ophthalmology, which is known as ESO, Consultant Ophthalmologist in Medical Retina and Uveitis. On behalf of Emirates Society of Ophthalmology, I would like to thank Bayer for their tremendous support to ESO and its activities. Firstly, as you saw in the video, 600 shields are on its way to our dear ophthalmologists all over UAE. Secondly, in conducting this evening's webinar, our main objective, as the webinar's title, which is Vision 2020, our speakers who are eminent in their fields are going to take us through their experience, highlighting and giving us the latest updates in management in each case scenario. Let me introduce our speakers. Dr. Patricio Lorenzo, Consultant Medical Retina, Dubai Hospital. Dr. Muhammad Awadallah, Consultant Vitreoretinal Surgeon, Qassimi Hospital. Dr. J. Kaliath, Medical and Surgical Retinal Specialist at New Medical Center, Abu Dhabi. Your question will be answered at the end of each talk. So if you have any question, kindly write it in the chat box and we will handle it and deal it as a panel discussion in after each talk. First of all, let me introduce our first speaker, who is Dr. Muhammad Awadallah.
Thank you, Bayer and ESO, for this kind invitation. It's my pleasure to be with you this night. I have a case presentation. I will go quick through it. The patient is a 67-year-old man. He has been diagnosed with diabetes for 30 years, hypertension, and he has a chronic kidney disease and is on dialysis. Is coming complaining of blurring of vision in the right eye. He had right phaco and pars plana vitrectomy and the left phaco in another hospital. Developed the right DME post-vitrectomy, and he had recent 3 ranibizumab intravitreal injection, and he reported at that time no reported visual improvement in that eye. He's a known glaucoma patient on topical anti-glaucoma medication. On examination, the vision in the right eye is 0.1, the left eye 0.3. Anterior segment examination unremarkable. He has bilateral pseudophakia. Intraocular pressure is controlled on the topical anti-glaucoma medication in both eyes. Fundus examination of the concerned eye, the right eye, as we can see, has bilateral vitrectomized fluid-filled eye with a regressed laser PDR, optic disc cupping, and diabetic macular edema. Here we can see the OCT scan of this vitrectomized eye, the right eye, with the patient complains of blurring vision. We can see the cystoid macular edema, intraretinal edema, thickness of about 400 micron, and there is some affection of the outer segment layers of the retina. And at this point, I would like to ask my colleagues, the attendees and the panelists, about the treatment options of this patient for the DME in this particular patient, who's, again, to summarize, his right eye is vitrectomized and he has a history of primary open-angle glaucoma. So we'll push the question for the audience. If you can kindly review the options and choose one of them. Yeah, so almost there are different opinions. We have Ozurdex injection, which is obviously a preferred treatment in vitrectomized eye for diabetic macular edema. The second option of the anti-VEGF, to continue with the anti-VEGF or to switch to another anti-VEGF, taking into consideration that the patient is a glaucomatous patient. Well, actually, this is what I did. I switched him to aflipercept since he had already 3 ranibizumab injection, which was recent with no improvement. The patient was given 3 monthly aflipercept injection, and by the 3rd injection, the best corrected visual acuity improved 3 lines from 0.1 to 0.4. Obviously, the patient is a vitrectomized ischemic retina and some affection of the outer segments of the retina. Still, he can see that there is dryness of the macula and some improvement in vision. After 2 months, still 1 injection for some intraretinal edema, and another 5th injection, 2 months, and best corrected visual acuity reached its maximum of 0.5. So at this point, I would like to ask the audience another question to post it, which is regarding the use of anti-VEGF agents in general with ranibizumab, aflipercept, in diabetic macular edema with prior vitrectomy. So let me push the question, what the audience think about their role. Okay, let's check the result. Yeah, most of the audience agree that unlike the many believe that because of the rapid clearance of anti-VEGF from the vitrectomized eye would be no response. Actually, there is a response. However, this would take a longer duration and needs more frequent injection. And this is what have the studies shown. Although drug clearance is more rapid with anti-VEGF, however, in human pharmacokinetic studies are lacking till now. There is a major study or sub-study of by Bressler et al. That showed clearly that eyes with diabetic macular edema and prior vitrectomy, they do respond to anti-VEGF injections on the long term for 3 years. So they have a slower response and they require more frequent injection. Again, still dexamethasone implant is the agent of choice in such eyes, obviously because of the clearance factor with the anti-VEGF. However, in some patients, like patients with glaucoma, there is a risk of increase of intraocular pressure. We may give anti-VEGF as a good option. However, we have to know that eyes that are vitrectomized, they are more severe disease that has been there for a longer period of time. They have poor baseline visual acuity. They have thinner retina, as we have seen in this patient. And although a favorable response with anti-VEGF on the long run is there, however, the overall response, visual response, would be less than the non-vitrectomized eye. Thank you very much, and I would like again to thank the ESO Empire for their invitation.
There's a question from Ahmed Al-Fatrawi. What the risk of increased IOP when the patient is vitrectomized is different than none or the same? This is always the question with a known history of glaucoma or a suspicious raising up IOP.
My opinion is the risk.
Can you hear me, Dr. Muhammad?
Yes, Dr. Noura. My opinion is the risk is the same, whether in vitrectomized or non-vitrectomized eye. The steroid, it depends on the patient, if the patient is a responder or not.
Okay. And how about you, Dr. J and Dr. Patricio?
Well, as mentioned earlier, it depends on whether the patient is a steroid responder or not. So that decides the IOP, right?
Yeah.
I agree. I think that if you have time to do something like a challenge test, maybe with some eye drops while you're injecting anti-VEGF, but thinking of going for maybe Ozurdex, because this case had some hyper-reflective spots that you might think that it is related to some sort of inflammation, and maybe a good candidate for Ozurdex. But I think we have had some bad experiences with Ozurdex and a very high intraocular pressure, having to remove one rod in one occasion. So I would advise to go for a steroid challenge before attempting in patients with already known glaucoma damage. I would like to ask to Dr. Aguadala, do you think that the vitrectomy
and how about if there's a patient?
Sorry. Yes. The vitrectomy itself could produce some macular edema in this case?
Actually, many suggest that because of the VEGF load in the vitreous, vitrectomy spread of all this VEGF load. So it's an observation we all see that macular edema just disappear after vitrectomy. And many think that this is because we get rid of the VEGF load already. However, still such some cases develop post-vitrectomy edema. So my opinion that vitrectomy helps to improve macular edema, diabetic macular edema very well. We see this all the time. Still, some cases are resistant.
Thank you.
So do you keep it as ILM peeling as a last reservoir trying with anti-VEGF and then Ozurdex, or there are certain cases that you say that you have this gut feeling that ILM is the best treatment option?
If you have already done
As a surgeon, VR surgeon.
yeah, ILM peeling, some surgeons do ILM peeling in such cases, especially in when doing vitrectomy with macular edema and traction. So, many cases we already do ILM, still macular edema doesn't go. If you know that there is ILM is still there, there is a syndrome called TOT ILM, and this TOT ILM causes macular edema to be there. And there are some studies about going again and peel the ILM in order to get rid of this edema. Anyways, those eyes really have a long history of diabetic maculopathy, diabetic retinopathy, a lot of PRP, laser, ischemia. Visual improvement is not that great. Some surgeons opt for just they don't do another vitrectomy, but unless you see this syndrome of a TOT ILM, which deserve a second try to peel it if you haven't peeled it in the first place.
Yeah, and just to bear also in mind and to not to overlook and disregard the risk factors, HbA1c, the hypertension, and all the risk factors, especially diabetes, and our poor control patients are really common here in the region, especially even in Emirates, and they come like they want like the magic with the huge DME or complicated diabetic retinopathy.
Sure.
So HbA1c and a good control, strong control, tight control with lipid hypertension. It's really it plays a big role. We cannot disregard this also in emphasizing the patients.
Sure, yeah. Totally agree with this.
Yeah, so there are no questions. I encourage our attendees to have the maximum information from our experts. So if you have any questions, please write in the chat box and we will deal with it accordingly. Dr. J, your next turn and the mic is all yours.
Thank you.
Thank you, Dr. Muhammad.
Thank you, Dr. Noura.
Outside, I would like to thank Bayer and Dr. Noura for the invite. It's my pleasure to be here today with you. So my patient is a 43-year-old male with blurring in the left eye, noticed when he went for a driving test 2 weeks back. So he gave history of injury many years back, probably 5, and had poor vision in the left eye, which he ignored. Best corrected visual acuity was 6.6 in the right eye and 6.36 parts in the left eye. Intraocular pressures and anterior segment were normal. Fundus was normal in the right eye. In the left eye, he had a large macular hole. This is a slightly brightened picture. You can see a large macular hole and almost 180 degree of choroidal scarring secondary to trauma. The macular hole had a basal diameter of 2000 plus microns. The question now is to operate or not. The points in favor of not operation of observation include long-standing hole, which is a risk factor, very large hole, another risk factor, and due to traumatic optic atrophy and scarring traumatic atrophy and scarring, more than 180 degree of retina cannot approximate. So closure is unlikely. A point in favor of surgery is that vision might deteriorate further with time on observation. But if the hole remains open, vision might drop even after surgery. So I would like to know an opinion from the audience to operate or not. The result is not, there is not a single person who said to operate. It's universal, don't, its opinion is straightforward, not operate. So I didn't expect it, but anyway, if you are going ahead with the surgery, what will be your choice? ILM peel, inverted ILM flap, retinal transplant. I'm sorry, I'm not able to post this question. Yes, okay. So the result is 11 for inverted ILM flap and 8 for retinal transplant. So I explained very poor prognosis as well as for anatomical as well as visual gain. Patient wanted to give it a try. So I decided to go ahead. This is an OCT picture from another another machine. You can see. So I did a double flap in this. I usually prepare 2 flaps, in case one is lost. So I flapped it from one side and flapped it from other side. And this is the post-op after 7 months. Okay. So you can see the hole closed nicely. There is some amount of scarring. You can see some scarring here. Okay, but the vision remained 636. This was a bit disappointing for me because the hole closed and I was expecting something more. So this made me sit and think, why is it? Are there any concerns with this ILM flap? So first, let us see how this flap works. The ILM peeling can induce gliosis and it helps healing. The peel of ILM contains molar cell fragments. If a segment of peel ILM is left attached, it may provoke gliosis both inside the retina and on the surface of ILM. So it works in both ways. Second point is that cells need a basement membrane to proliferate. The ILM can act as a scaffold for tissue proliferation. Reactive Muller cells might preserve tissue function by the release of antioxidants and neurotrophic factors and may contribute to retinal regeneration by generation of neural progenitor stem cells. So this is how it works in short. So are there any concerns? The problem is that we have no control on the gliosis by Muller cells. There is risk of excessive gliosis. Michailivska, who reported ILM flap for the first time, mentioned that OCT after ILM flap revealed hyperreflective lesions suggestive of excessive gliosis in the fovea. The persistent activation of glial cells may contribute to tissue damage. If it results in scar, it may limit the recovery of ellipsoid zone. So these are the concerns. If Muller cell gliosis result in glial scar, it can contribute to neurodegeneration. Excessive gliosis has cytotoxic effect on retinal neurons. Glial tissue may secrete tumor necrosis factor alpha, a potentially neurodestructive cytokine, which can result in worse visual prognosis. So it's not a completely safe, and it can if it is excessive gliosis and gliosis is excessive, it can affect visual prognosis. So what is the literature? What does the literature say? ILM peel and flap. ILM peel and flap versus ILM peel alone? Is there significant improvement in vision at 6 months? I have to say literature is divided. But more and more studies in 2018, 2 studies, 2019 by Dr. Rajat et al. And 2020 are suggestive that there is no significant visual improvement with ILM peel plus flap versus ILM peel in large macular holes. But on the others, but they got better anatomical improvement, anatomical closure with ILM peel with flap. But on the other side, there's a large study by Rizzo et al. Where they obtained statistically significant visual as well as anatomical visual improvement as well as anatomical closure. So literature is divided. Before ILM flap era, we were confident that most macular holes will close with just ILM peeling and face down positioning with good visual results. But now the fashion is to flap all macular holes. Is it helping vision? We are not sure. What we need is the right amount of gliosis to close the hole. But the reality is that we can enhance but cannot regulate the degree of gliosis or prevent excessive gliosis or scarring with ILM flap, as seen in this picture. In this case, probably ILM flap is justified because there were multiple risk factors. So to maximize patients' vision, our theme Vision 2020, for macular holes which are not very large, say 650 or 700 microns or smaller, isn't it better to just peel and allow to close rather than introducing the risk of flap and possible excessive gliosis and scarring? This is the idea I wanted to put across for discussion. Thank you.
Thank you, Dr. J, for the surgical case. Actually, before there are a couple of questions. Is he around, Dr. J? Yes, Dr. J, thank you so much for your presentation, the surgical case. Do you think that 650 is like not a rule of thumb, but even does it matter if it's less or the vision? If it's deteriorated the vision, do you only depend on OCT for the macular thickness and your surgical, or also the vision? So what's this, your mind map and macular hole surgery in general?
Well, unless the hole is very large, like say more than 800 microns, I do not do a flap. And whether to operate or not, decision is based on patient expectation. As it's larger the hole and as duration is longer, I inform the patient that we might fail. We can give it a try, but we might fail. Visual prognosis is guarded. So it depends on patient expectations. If regarding operations to operate or not.
Yeah. Especially the expectation, as per our title, webinar's title, Vision 2020, the expectation should be like even in consent that the visual prognosis are guarded. How about you, Dr. Abdullah?
Actually, I was in agreement with Dr. J about to go for surgery, and I posted the yes for surgery, but unfortunately, the overwhelming audience didn't like this. I have some experience with such large macular or very large, what we call giant macular holes. Vision do improve sometimes, but expectations shouldn't be that much. It can improve by 1 line, 2 lines, and the earlier you operate, the better the response. Obviously, Dr. J's case is 5-year duration, and there is trauma approaching the fovea and a lot of RPE affection. Again, I would go for surgery and do the same. Nice surgery. Unfortunately, the patient didn't improve, but I had cases. Few cases of the same with some improvement of vision, even not only gas with silicone oil as well. So I commend surgery by Dr. J, and still in disagreement with the audience.
Till this case, I never thought ILM flap can have some ill effects. I thought it's like, whatever good it can do. That was my thought process.
Yeah.
That's why I wanted to highlight this aspect.
I have cases of such giant. Obviously, the basal diameter of the hole is almost like one disc diameter.
Now, one thing is, I remember my first macular hole back in 1994. And at that time, we used to put a concentrate of blood cells after peeling and doing the macular hole. So the fashion is just changing what you put, try to plug the hole with something, free flap, inverted flap. Some people has used capsule of the lens capsule. I don't know, we have seen so many techniques that has been very fashionable, and in the end, it didn't produce any difference from maybe just the straightforward procedure or observation. Myself, I voted no. I don't know. In these cases, I could always ask for a second opinion.
Yeah.
Well, and nobody voted yes. Actually, I was shocked.
That was a great case.
I have case. I have done case a couple of cases with just ILM peeling without any flap, and surprisingly, such a giant macular hole do close. So yeah, I agree that maybe you don't have to do those questionable things, Dr. Patricio.
Yeah.
When you say, Dr. Muhammad, giant, like your case that you did it without flap, how much was the macular hole? How much was it?
It was even bigger than Dr. J's. The basal diameter is like 2,000 something.
Super giant then.
Yeah.
Okay.
Studies has proved beyond doubt that large macular holes have a very poor prognosis. So yeah, I do agree they have really poor prognosis. Many cases they just don't improve.
Yeah.
So
the transparency and the to have the the full preparation.
Vision wise, and even the closure wise.
Yes.
Anatomical closure.
Yeah. We have a couple of questions from Dr. Ahmed Satrawi. Is there any study compared the ILM flap with retina autograft? I mean, in regard of functional and anatomical outcomes, because the graft, as he wrote, also has good anatomical outcome, but very limited functional. What do you think about that?
I'm not sure if it is directly comparable, because those patients going for an retinal autograft are bad cases. So, and when I was reading for this, I found that a lot of variations. Some studies they use air. Everything matters, whether air or gas and prone positioning. Everything matters. So I'm not sure whether it's directly compare. We can compare it one to one, unless everything is matched.
Yeah. Our dear colleague, Dr. Ala Atawan, he's a veterinary surgeon in Tom Hospital in Al Ain. He asked, what was the vision of the patient?
Vision was 636 parts. Means he couldn't read 636 properly before the procedure, and after the procedure he could read 636. So probably the optometrist would have tried a little hard, because surgery has been done. So I can say 636 parts and it became 636, but it's like patient was happy because I could show him the hole is closed. So.
Yeah, the satisfaction is really important. Like the surgeon, the patient, and even the optometrist, she did her job. Yeah, and regarding the last question from Qasim, I would like to know about our speaker's experience on Ozurdex effect on IOP in glaucoma and non-glaucoma patient. Is it significant elevation would be controlled on eye drops? Any cases refer to surgery? This one, this refers to the, I think, first question, first topic.
Yeah, please, Dr. Patrick.
Go ahead. I already reported one of our patients who actually got an intractable, acute glaucoma, acute but not acute angle closure after Osurdex. And we have to do a vitrectomy, perform a vitrectomy and remove the rod and then trabeculectomy. It was impossible to control. But I would say also that we have many patients treated with Osurdex. This was the only case. Most of them are controlled in my humble experience with drops. No need for surgery in majority of cases.
How about you, Dr. Awadallah or Jay?
Ozurdex is always the best option for vitrectomized eyes. If well-controlled glaucoma, I would do Ozurdex as well because of its very effective and the longer duration. However, it's a kind of a customized. This particular patient, I thought optic disc was not in great shape, and actually. Ozurdex is always, you can control it most of the time with anti-glaucoma, topical anti-glaucoma. However, if there is an intractable glaucoma, you will go for glaucoma surgeries, and I don't think a glaucoma surgery in a vitrectomized eye is a nice thing. You would have a sit-on or shunt operation, sometimes cyclo-destructive.
What I do, if the intraocular pressure is in the low teens, I directly give Ozurdex. If it's high normal, like in 20s, I do a steroid challenge test as suggested by Dr. Patricio always. If it's patient is non-glaucoma patient, I avoid Ozurdex as far as possible. I have one experience of doing vitrectomy for Ozurdex. That was when Ozurdex was introduced. It was introduced in India much earlier than it was introduced here. So the drug was new. I had informed patient about all those stuff, and IOP went very high. And I also did not have much experience, how it will impact the eye. So I did the surgery. But now I don't think I will operate. I will do vitrectomy. Because we know the drug and we know how it works on. We have to hold on for 3 months maximum. So it was in the very early days, just after Ozurdex was introduced. So at that time I did one vitrectomy, but that's all. After that, I never did any surgery for any Ozurdex related intraocular pressure rise.
Well, I agree with you all, and as we are ophthalmologists, we are aiming for the best corrected vision, and as it's compatible with our webinar, Vision 2020, nevertheless, we have to introduce for any management or treatment, whether therapeutic or medication or surgical, we have to think overall, overall the situation, background of the patient, family history, any previous history, and even also we have to tailor or customize the management according to the status itself. So, and mind you also that the theme of the webinar to like Vision 2020, we want the patient not like the sharp or the best vision, corrected vision to gain anatomically and even vision-wise with the least complication, inshallah, away from high intraocular pressure. Okay, so no more questions, and we thank you so much, Dr. J.
Thank you.
Now we are going for the last speaker, but not the least, Dr. Patricio. The floor is all yours.
Thank you, Dr. Noura. Thank you, Bayer, for inviting me to this presentation. Let's see if I can, maybe Mark can show my. It's only 96 slides, so we will try to do it as fast as possible. This is a personal problem he had. On examination, He had a corrected vision of 0.05 for the right eye and 0.2 for the left. Nuclear cataract in both eyes. The fundus, we saw a disciform macular scar in the right eye, and at the left eye we saw some RPE changes, tilted disc. So we did an OCT, and we can see here at the OCT some epiretinal membrane here, and some subretinal fluid here and here, double layer sign. Then we did an OCTA, and we can see here a choroidal neovascular membrane. There is blood flow on top and below the RPE, so this is a mixed type 1 and 2 choroidal neovascular membrane. So we treated the left eye of this patient with 3 intravitreal injections, and after 3 months the visual acuity came to 0.3 from 0.2. We did an OCT and OCTA 1 month after this loading dose, so 4 months since the beginning. And we can see now that the macula is dry, there is no subretinal fluid. And on the OCTA, we can see that still the membrane is there. So I think that now the question is, have a look and see if I can manage the questions, please, Mr. Mark. I cannot. I don't have the panel to go through the questions. Hello? Okay, anyhow, we'll go ahead. So what is next for this patient? We can do something like
Dr. Patricio?
Yes, yes.
The question has been pushed and the results is B6 and C11.
Okay, fine. Fair enough. So what we did was no treatment. We decided on going for PRM with this patient, and you will see now that after 3 months later, there was no interretinal fluid. The membrane was still there. So again, no treatment. 6 months later, there was no subretinal fluid. Membrane is still there. No treatment. 10 months later, still visual acuity the same, 0.3. And remember, we are not treating visual acuities, we are not treating OCTs, we are treating human beings, and we have to put everything together. So 10 months later, the patient had again subretinal fluid, and the membrane, maybe there is some lateral extension here, maybe. So the question is, what's your take now? Can we push forwards the question, Mr. Mark? 1 injection only, as he was on PRN. Loading dose again with 3 anti-VEGF, or wait and see for 1 more month.
Resume. The highest rated is B.
Loading dose again. Yeah, that's what we did actually. As the patient had a good response for the first time and he was free of treatment or without treatment for 10 months. So we gave the patient 3 intravitreal injections, and this is the result after what happens here. Okay, we can see that after the 3 intravitreal injections, the membrane is still there present, maybe enlarged, and still there is subretinal fluid. So, what is next? Continue with the same anti-VEGF for 2 or 3 more months, and then PRN, with the same, and then treat and extend. Switch to another anti-VEGF with loading dose and PRN. Switch to another anti-VEGF with loading dose and then treat and extend, or switch to another anti-VEGF without loading dose and continue PRN, or you are just nearly lost and you need some help. And again, you have to make the plan for your patient. You have to think ahead, trying to reach this 20/20 vision, improve our patient's vision, no matter.
It was C.
C. Okay, switch to another anti-VEGF with all the dose and then PRN. Okay, we actually didn't do that. We switched to another anti-VEGF, but we went for treat and extend. And then I will show you the results. This is the patient OCT after the loading dose, no intraretinal fluid. The membrane maybe a little less, but still there, of course. 20 months later, the macula is dry, membrane is still there, maybe a little bit fainter. 22 months later, dry, membrane present. 26 months later, dry, membrane. I don't see the membrane, too many artifacts. 28 months later, visual acuity 0.4, macula dry, membrane a little bit more faint. 31 months later, visual acuity 0.5, no fluid, membrane definitely less well defined, and then our tritone machine broke down, but still we managed to get this 34 months later. This is actually 37 months after the first appointment of the patient. And here, as you can see, the macula is dry, visual acuity has come up to 0.5 from 0.2 in the beginning. So the conclusion is never give up. There is not a definite answer for a group of patients. Protocols are unfair from my point of view. Treat and stem has to be tailored for every patient. Sun eyes will show the CMV for years and years to come with no exudation, no activity. Intraretinal fluid does not always equal activity. And slow or no vision gainers in the beginning can still improve after 2 or more years. Thank you for your patience.
Thank you, Dr. Patricio. It was a long. Yeah, it seems that you're really patient. You waited a lot for on the patient.
Either the patient give up or I will never give up.
Yeah, you showed that really you're a patient, and this is like a dilemma: when to do it and when to inject. Any input from the speakers before a question that it has been raised. I encourage all the audience to have, if you have any questions, you can just type it in Q&A before we close up. Okay, there is a question from our dear colleague, Dr. Ala Atawan, that he commented that he would treat and extend by 1 week each time.
Yeah, I just said that there is not anything that you can use as a protocol for a predetermined patient. Unless proven otherwise, any regime could be fit for your patient. I cannot agree more with Dr. Ala, because I mean, he might be as right as I was because I had a good result with this patient, but maybe he can have the same result. That's something that is, of course, broadly accepted. There is not something like, as I said, fixed protocol for every patient.
Mm-hmm. Yeah, tailoring according to the patient. We tailor our
correct.
Yeah.
Yes, right.
Okay, so no more questions. Before closing up and before giving the mic to Bayer's team, they want to have a talk to the audience. I would like to thank our great speakers, my dear colleagues in Emirates. Hope to see you soon. Thank you, Bayer, for your tremendous support, Razan and Lima. Thank you, Mr. Mark and Selma. Would like to announce also again, since that at the end of the session, that we are proudly going to distribute 600 shields in collaboration between ESO, Emirates Society of Ophthalmology, and Bayer, to all our ophthalmologists all over Emirates. And this is the breath slit lamp shields, which can be fit on the slit lamp or on laser machine, and on any type of slit lamp. And there is a video, and thank you so much, Bayer, for your support as usual. And there is a video before talking and giving the mic to Razan and Lima. Thank you, and wishing you to stay safe and to meet you soon in person.
Thank you, Dr.
Thank you.
Thank you. The video, Mark? Assalamu alaikum wa rahmatullahi wa barakatuh. Dear colleagues, health and safety are the two major concerns in each organization in every country. Therefore, Emirates Society of Ophthalmology, in collaboration with Bayer, have taken the initiative to distribute slit lamp breath shields among all the ophthalmologists within UAE. Wishing you to stay safe.
Thank you for the ESO and Bayer for their initiative to provide medical shield for the slit lamp. I will be fitting it on the slit lamp here. It fits well in place and with a good thickness to provide safety and security for all of us as ophthalmologists. It fits for the slit lamp and the laser machine.
For generations, people have trusted Bayer for solutions that promise to live healthier lives and provide sustainable support. These solutions are ever important nowadays.
For that reason, protecting the safety and well-being of our doctors is paramount commitment in our partnership journey.
Where together, in collaboration with ESO, we can pave the way for a better and safer future for the ophthalmology community and their patients in UAE.
Good evening, everyone. Good evening. It's not the beginning anymore, actually. We don't want to hold you more. On behalf of Bayer team, we would like to spread our sincere gratitude for having your valuable attendance. And actually, big thanks to our eminent speakers and for their interactive and exciting stories. A special thanks to Dr. Noura Qassimi. It was an honor for us to have this Vision 2020 in collaboration with the ESO.
Last but not least, please rest in mind that buyer vision is always meeting your vision, which is provide our patient the best side they deserve. We don't Thank you, Lisa. Actually, just for saying goodbye to everyone. Again, I would like everybody was thanking the speakers, and Dr. Noura was introducing and thanking each one of them. So I would like to join and thank them all for their actually interactive discussions, for their interesting stories, and for their flexibility also to be there with us today. But for me, I would like also to thank Dr. Noura. I believe we took a special spot this time because this is, I think, the last for this year 2020. So we're honored to be partnering with people as usual, and all of our societies in UAE. And at the end, I would like to say that maybe the best thing about the year of 2020 is just the number, the 2020. We have faced a lot of issues in this year. But finally, I would like to say that Vision 2020 as a meeting will be complete, and hopefully we can have our last meeting of this year in 2 months, and it will be as special as expected. Stay safe. Thank you so much, and have a good day. And also thank you for our event management team for their also collaboration with us and for their support. Thank you, everyone. Goodbye.
Thank you.